I'm Naja Swat, and I'm speaking to Dr. Daniel Clauw. He is a professor of anesthesiology, medicine, and psychiatry at the University of Michigan, and also the director of the Chronic Pain and Fatigue Research Center at the University of Michigan. So this is quite a comprehensive field that we have to discuss today. Dr. Clauw, thank you so much for your time.
Sure.
You're a leading expert in the field of chronic pain. Why chronic pain? What drew you to the field?
I'm clinically trained as a rheumatologist, and early on when I was seeing patients, we knew of a condition that was called fibrositis at that time, where individuals had widespread pain and fatigue and sleep and memory problems, but we didn't really know anything about what caused it. And so I thought that was intriguing. And I believed that the patients really had something wrong with them. And I happened to, early in my career, stumble upon studying a disease called eosinophilic myalgia syndrome, where people that were taking a nutritional supplement, tryptophan, developed this really bad autoimmune disease because of a contaminant in the tryptophan. Anyway, I wasn't really originally even a researcher, but that early involvement with that disease, where I sort of helped identify the disease and then do research on it, got me super interested in research. And then the next big problem that was sitting in front of me as a rheumatologist was fibromyalgia. So since early on, I've been interested in doing research, and then surrounding myself with groups of people that knew different research methods, like functional brain imaging, that we could apply to conditions like fibromyalgia.
And are you privy to any sort of ballpark statistics of, the amount of people, the percentage of the population who is suffering with chronic pain?
With chronic pain, it's usually about 30 to 40% of the population. There's a smaller number that have what's called high impact pain, where the pain is severe enough to be really functionally limiting them. But that's 15 to 20% of the population. So it's a very common problem.
And how much of the cases are psychosomatic pain, or at least partly psychosomatically driven?
I don't like that term.
It's difficult because it makes it seem like it's in their head, but it's very real.
Right. So psychological factors undoubtedly play a big role in acute pain, chronic pain, transition from acute to chronic pain, but there's a lot of non-psychological factors as well. And so I sometimes rant about the over-psychologicalization of chronic pain. And these factors are important. We should identify and treat them, and some of them are even helping cause the pain. But a lot of times the anxiety, the depression, the catastrophizing is because of the pain, that people have these symptoms because they hurt, or because they're fatigued, or they're not sleeping well, but they feel terrible. And because of that, they develop psychological problems. So I just want people to understand that there's a bi-directional relationship between pain and all sorts of different sort of psychological problems, and that to understand that, and to not intensely focus just on the psychological issues when you're thinking of someone with a condition like fibromyalgia.
And apart from fibromyalgia, what are the other physical drivers behind chronic pain? And if you can also distinguish between acute pain and chronic pain.
So acute pain is, pain that you have when you fall off a bike, you have a surgical procedure, you damage some area of the body and it hurts. And that chronic pain is arbitrarily defined as pain in the same area of the body for 3 months or longer. And usually it means that you've had pain like half the days in that area of the body for 3 months. But there's, gray zones between acute and chronic pain, and a lot of it is that anyone that has chronic pain usually has more chronic pain in different regions of the body. And one of the main advances in the field of chronic pain in the last couple of decades has been understanding that some pain that is more due to a problem in that area of the body, that's called nociceptive pain, it is due to damage or inflammation in the region of the body where you're experiencing the pain. There's something wrong in that area of the body. But some pain in that same region of the body can be more of a brain problem, more of a spinal cord brain problem, where the spinal cord and the brain are amplifying pain signals throughout the entire body, and it can cause people to feel pain and experience pain, even in regions of the body where there's not any damage or inflammation. And so that's what conditions like fibromyalgia, a lot of the more common chronic pain conditions, like a headache, best good example, very common. You don't have like inflammation or damage in your brain when you have a headache. It's more, again, there's different mechanisms in tension versus migraine headache, but I think people intuitively know it's not that there's some sort of damage or inflammation. But things like fibromyalgia, headache, irritable bowel, a lot of kinds of chronic pelvic pain, including endometriosis, a lot of low back pain, is actually coming more so from the centrally driven pain that unfortunately now is called nociplastic pain. That's the scientific term for it. But I think that the term that's more helpful to explain it to patients and to non-scientists is central or centralized pain, that the pain's coming more so from your central nervous system than the periphery. And that's really helpful because it makes sense that then you'd have to use treatments that are more aimed at like turning down the amplifier in the central nervous system rather than treatments that are like surgery or injections or certain types of drugs that are going to work better if the pain is coming from damage or inflammation in that area of the body.
Is this related to central sensitization? That
yes,
concept?
Same thing. It's another term, right?
Okay. And how do you treat pain that is caused by those factors? Are opioids effective at all?
No, opioids. I don't think opioids work very well for any kind of chronic pain. They certainly don't work well for this kind. They often make this kind of pain worse. A lot of integrative therapies first get people sleeping well. Sleep is extremely important, and this kind of pain including there's apps for things like CBT for insomnia, cognitive behavioral therapy for insomnia that can be extremely helpful for chronic pain patients. Just getting sleep, deeper sleep, and more regular times that you go to bed and wake up and things like that can be extremely helpful. Getting more physically active. A lot of people with chronic pain, because your body's telling you don't move that area of the body, they become really inactive, and inactivity in and of itself can cause pain. So we have to keep people moving, and we have to try to get them more active. And so I always say start getting with sleep and activity and then move out. I think a lot of other integrative therapies, things like mindfulness, the different yoga, Tai Chi, acupressure, all kinds of different types of cognitive behavioral therapies. And there are drugs that can be helpful as well. There are, drugs that work more so in the central nervous system to turn down the volume control for pain, like drugs like duloxetine, the drug that went by the name Cymbalta, or drugs like pregabalin, which also goes by Lyrica. Those can be somewhat helpful. Some cannabinoids might be somewhat helpful in patients. We're doing work now with psychedelics. I think that at some point, psychedelics, especially for the subset of individuals that has had a lot of trauma, that has chronic pain, I think that it's possible that psychedelics might be helpful in helping then get therapy that might really allow people to get resolution of some of these things rather than, there's not one way in which people get this central sensitization or nociplastic pain. And there's certainly not one simple way or one simple drug that's going to work to treat it. It's a lot of non-drug approaches, though. It's more an emphasis of, again, integrative approaches that work for a lot of medical conditions, not just pain.
Except my sympathy goes out to people with chronic pain, because I think a lot of the time they end up at the neurologist and it just makes them feel crazy, because nothing can be found in the body that is a direct cause for this chronic pain. And it's real. It's very real. And then they are told it's neuropathic pain. They don't really understand what that means. And so it's very hopeful that people are looking outside of normal circles into things like psychedelic treatment. Has the research gone into ketamine treatment for chronic pain? Because that is actually, in South Africa, it is now legal to treat chronic pain with multiple sessions of 3 to 4 hours of ketamine infusions. Have you looked into that?
We, in our immediate group, we haven't, but other people here at the University of Michigan have. In fact, Ed Domino, the person who sort of invented ketamine, was from our pharmacology department and sort of a giant here. But I don't know that we know yet what its role is, the infusions and things like that. It's sort of the Wild West. As soon as people can make money off of doing something by doing an infusion or then all of a sudden science goes out the window and it just gets, used a lot. So, but I think those things can be helpful in some individuals in the right setting. It's just there's not great data for ketamine.
And do you ever treat patients personally, or are you just involved in research? What would you?
Now, I earlier in my career I did more patient care, but I'm just a researcher.
And if a patient is on a sort of regimen of treating themselves with opioid addiction, with opioid medication, would you take them off? How do you address the challenges of opioid addiction with regards to patients or, people that have tried it in the past and are now having trouble with that? Because, that's a huge problem in and of itself.
A couple things. First, usually the problem isn't opioid addiction. It's that someone with chronic pain is on an opioid, and so that's where I'll start. The first thing is for the patient to make sure that that opioid is really helping their pain. If they haven't done a slow, gradual taper, they should, because these studies aren't well done, because it's hard to do studies of opioid taper. A lot of patients don't want to taper their opioids, but the scientific studies that have been done suggest that at least half of people that do a slow, gradual taper of opioids either have no change in their pain or their pain actually gets better. There's clearly a subset of people whose pain gets better if they come off of opioids. So the first thing I would say to a patient that's on opioid, I never suggest that I'm taking someone off of opioids. What I suggest to them is, if you're not sure you need to be on that drug, do you know for sure you're not one out of two people that isn't really being helped by that drug at all? Maybe you're having side effects of the drug that you've had for so long that you don't even know them. A lot of people that come off opioids say that their friends say they're back to their old personality. They're not constipated anymore. They're not foggy brain anymore. And so I think that what I used to do when I was talking to patients about this is just talk to patients about, these are really dangerous drugs. The studies show that if a chronic pain patient is taking an opioid, the risk of them dying of all-cause mortality, like of anything, the next year is double if they weren't taking that drug. And it's not because of addiction. People get too focused on like the addiction of opioids and the overdose. That's not, people with chronic pain are by and large not dying of overdose, but being on an opioid makes you a much higher risk of having a suicide, of having a myocardial infarction, of having a motor traffic accident, of having a fall. And those things cause death. And almost no one that was put on an opioid a long time ago was told, if you take this drug, it's going to double your risk of dying, and that's a huge risk. Like wearing a seatbelt increases your risk of not dying by like 1.1%. Like doubling, going 100% increase in your risk of dying is a big deal. And do you want to accept that? Are you sure that the drug is helping you so much that you want to accept that risk? So that's how I think this should be, explained to patients that are taking opioids. I don't want to take the opioids away from them if the opioids are really helping them, but are they aware of that those risks that have nothing to do with overdose and nothing to do with addiction? And are they benefiting enough that they want to continue to take that risk?
What have you found to be the biggest misconceptions that people generally have about chronic pain?
Well, that if you can't see it on the X-ray, it's all in their head. But that's, I think we've made big strides with the legitimization of conditions like fibromyalgia, and even this. I don't love this term, nociplastic pain. In fact, I dislike it, and we wrote an editorial saying it was a stupid term when it first came out. But at least in the international group of pain researchers, and now it's really rapidly spreading as more and more physicians begin to learn this. It's sort of legitimized that that's very real. People aren't making this up. That's and in fact, outside of the United States, the ICD criteria, the International Classification of Disease, is a bigger deal than it is in the United States. And all of these same conditions that I was alluding to earlier, like fibromyalgia, headache, irritable bowel, are now called primary pain. And what that means is that the pain is the primary problem. It's not due to damage or inflammation. It's not due to osteoarthritis or lupus or rheumatoid arthritis or that's the primary problem. And that, the kinds of treatments that I talked about earlier are the preferred treatments for that kind of pain, not surgery or injections or opioids.
And in your research center, what are you currently working on? What projects or sort of research insights do you have over the last few years into chronic pain, fibromyalgia, those other issues we've discussed?
We have a lot of ongoing studies. We're a really big group, a lot of ongoing studies. A lot of them are some of the things I've already been alluding to. Some of the other kinds of things that we're very interested in is studying the new onset of this kind of nociplastic pain as children go through adolescence, go through puberty, and develop this kind of pain, but really having a sort of a bigger research program in the sort of pediatric and adolescent pain space, because we think this is when a lot of these conditions occur. We published a study that I think is one of our most important studies where Chelsea Kaplan in our group showed mining a very large ongoing study in the United States called the ABCD study that takes children when they have to be healthy at age 9 to get in the study, and it follows them until they're age 18. And it does functional brain imaging every 2 years and asks them all sorts of different questions as they're growing up. And we know that some of these children will develop different conditions, and it allows us to study like new onset of different kinds of conditions. And that study wasn't originally set up to study pain, but we were able to find a couple questions in there that were pain related that allowed us to look at the kids who were healthy when they entered the study at age 9 that developed new pain in several areas at age 10, and call those the cases, and then the controls were the kids that didn't develop new pain. And we saw on brain imaging in those kids that were age 9 that had no pain, they were totally healthy, their brains on functional MRI looked at like 3/4 like an adult with fibromyalgia looks, but they were still not symptomatic, so that we could really sort of see that they were at risk for developing this. And that's really, exciting from a research standpoint, is like if we can understand why that transition occurs, how it occurs, how we could identify some of those children that are at risk for developing central sensitization, fibromyalgia conditions, and intervene earlier, get them involved in, make them understand that if they sleep regularly, if they exercise regularly, if they do things like mindfulness or meditation, they might be way better off and way healthier. I really think we could prevent a lot of this kind of pain by just better understanding that there's a subgroup of people that are otherwise going to be predisposed to this, and let's understand how and why this occurs biologically, and also understand how we could move back. Because I think if someone if someone is diagnosed with fibromyalgia at age 40, it often means that they've had like 20-25 years of untreated or maltreated pain. And most diseases, if you wait 20 years to treat them, you can't treat them very well, because there becomes a component of irreversibility to it if you wait that long. And so I think one of our biggest challenges is to identify these individuals and help these individuals much earlier in the course and get them involved in some of these more integrative, multidisciplinary programs that would be of a lot of benefit to them.
And have you found a particular subset of the population that are more likely to present with these symptoms, and a particular age group, if it's female, male?
Yeah, so female's going to be 1.5 to 2 times more likely to develop this kind of problem than male. That's the sort of one of the biggest risk factors, if you will, and in it, because there doesn't seem to be much difference in pain or pain sensitivity in boys and girls before they go through puberty. And so female, and then again, we see that poor sleep that is a risk factor for developing these kinds of problems. Not surprisingly, a number of sort of low socioeconomic status factors put you at risk for almost any kind of disease, and certainly put you at higher risk for these types of conditions. Being exposed to different types of stressors can, trigger these in some individuals and subsets of individuals. So it's multifactorial. We sort of understand clinically how these occur. And again, we think this is the major mechanism behind things like long COVID, is that the literature is now pretty clear that a very similar illness to long COVID can be triggered by infections like Lyme disease. There have been all sorts of other types of infections before COVID. We wrote an editorial 4 months after the pandemic started saying this is what long COVID is going to look like. And sure enough, it looks like sort of chronic fatigue, fibromyalgia-like syndrome. Again, probably in those individuals that in that study I was just alluding to earlier, that at age 9, their brain is predisposed to develop this. So if they have something like the infection, or if they get deployed to war, we've also done a lot of work in the post-deployment syndromes. At our annual conference in Ann Arbor every year, we highlight different topics, and this year we're highlighting post-war syndromes in Israel, Gaza, and Ukraine. We're having physicians that are treating the civilians in these regions that have high rates of conditions like fibromyalgia because of the war and the trauma and the stress and how it just disrupts day-to-day life. So anyway, it's really sort of increasing knowledge and understanding about these conditions, and that they're not all these like different things. Like post-COVID is different than Gulf War illness is different than fibromyalgia, and it's the same core symptoms come up over and over again. And again, I think we're getting a better understanding of how to treat them.
And just to close off with, I spoke to Dr. Howard Schubiner, and he has sort of developed a theory about the mind-body syndrome, and that you can, if you break the connection between your physical pain and your mental sort of corresponding frame or something like that, then you can break that tie, and that people have actually healed just from approaching it this way. What's your outlook on that?
I like Howard. I know Howard. We published several studies with Howard where we actually used his model in fibromyalgia and showed that it didn't really work. It worked in any higher proportion of patients than some of the more commonly used types of cognitive behavioral therapy. But when it worked a lot better. So I think that type of therapy can be super helpful in a subset of patients. But I would say that Howard, like other people I've been critical of in the pain field, has over-psychologicalized chronic pain. That is not for everyone. It's not like everyone with fibromyalgia is going to respond magically to this type of therapy. There's a subset that will, but there's a big subset that there's a lot of other types of treatments that can help those individuals. Maybe they have more of a sleep problem. Maybe they're, but it's really an integrative approach that's needed, and there's no magical therapy that's going to work in everyone.
And just, is it quality of sleep or is it duration of sleep? How important is quality of sleep?
Mainly it's quality of sleep, probably getting into deep sleep. And again, in some of these conditions, the sleep is like inherently disturbed. It's like there's sympathetic discharges like that are probably keeping people awake. So it may be that some of these more calming therapies, like mindfulness or things like that, are working to sort of reduce some of this.
Dr. Clauw, thank you so much. I really appreciate the time to speak to you about this. I have spoken to a lot of people who are struggling with this, and you sort of get to a very painful psychological place when you run out of resources and just don't know what to do. So for those people, and I'm speaking on their behalf, thank you so much for your time and for the research that you're doing.
Yeah, and send people the website, the Chronic Pain and Fatigue Research Center. We have a lot of videos, a lot of resources. We have a website called painguide.com. This is all free. We get a lot of funding from the federal government, and we feel responsible to try to put material out there to help people.
All right. Well, I'll add those links in the description to this interview. Thank you, Dr. Clauw.
Okay. All right. You take care.